Hi, my name is Alessandro Vannucchi, and I am Associate Professor of Hematology at the University of Florence. I'd like to speak with you about the EXPAND study. The EXPAND study is a study of ruxolitinib in patients with low platelet count. The EXPAND study aims indeed to evaluate the safety of ruxolitinib and to establish a maximum safe starting dose in patients with platelet counts that are between 99,000 and 50,000. This study is, of course, originating from the fact that in COMFORT studies, only patients with more than 100,000 platelets were allowed to enter. So the study has two different stratums, stratum 1 and stratum 2, that includes patients with 99 to 75,000 platelets, and in stratum 2, 50 to 74,000 platelets. So patients are treated with increasing amount of ruxolitinib and in order to establish the maximum safe starting dose. And then there is an expansion phase, a safety expansion phase, where 10 patients for each stratum are additionally treated as in addition to those who have already received that dose and followed, of course, for safety, first of all, and for efficacy. An interim analysis has been pre-planned for when the last patients had been enrolled in the dose escalation phase and had completed the core study. That means until day 168. At the data cutoff, we have information about 46 patients, 27 in stratum 1 and 19 in stratum 2. And now we have the information that 37% and 58% of the patients are still receiving treatment in stratum 1 and stratum 2. As expected, the primary reasons for discontinuation was adverse events, but adverse events that have been reported are totally consistent with the known safety profile of ruxolitinib. And indeed, the most common adverse events that were recorded in these patients are represented by thrombocytopenia and anemia. At the maximum safety dose, thrombocytopenia was also the most frequent adverse event. However, in terms of safety, it must be underlined that there was no dose-limiting toxicity in stratum 1 and only one dose-limiting toxicity represented by grade 4 thrombocytopenia in patients enrolled in stratum 2. So these quite complex and busy plots are reported here just to show what happened about hematological toxicity. And so in the upper part, you can appreciate the changes in hemoglobin levels that, as expected for the action mechanism of ruxolitinib, decrease along all groups, but however, no grade 4 anemia was reported. In the lower part of the graph, you can appreciate the decrease in the platelet counts. However, it was observed that platelet counts decreased mainly over the first 4 weeks, and then in most patients, the platelet count stabilized. In terms of efficacy, there was evidence of activity both in terms of spleen length reduction and improvement in symptoms. A spleen response was obtained at week 24 in about 41% of the patients in stratum 1 and 30% of the patients in stratum 2. A spleen response means a reduction of at least 50% in the length of palpable spleen from the left costal margin. And these reduction in the spleen length were also maintained over time because they were maintained at least up to week 24 in the patients who received the treatment. In terms of symptoms, there were evidences of improvement in symptoms that were measured by the MF-SF total symptom score in about one-third of the patients in stratum 1 and 60% of the patients in stratum 2. And the improvement in symptoms regarding all the different categories of symptoms that are ascribed to the enlarged spleen or the constitutional symptoms and so on. So there was evidence of clear efficacy in terms of spleen volume reduction and symptomatic improvement that were consistent with the results in COMFORT 1 and in COMFORT 2 studies in patients with a platelet count higher than 100,000. So in conclusion, this interim analysis from the EXPAND studies strengthens the idea that ruxolitinib can be safely administered in patients with MF and thrombocytopenia, starting with a lower dose, as of course in patients with platelets higher than 100,000. The kind and the number of adverse events that have been observed in this population were no different from what expected from the action mechanism and the previous experience with ruxolitinib. And on the other hand, there was enough evidence of activity of ruxolitinib even in this patient population that was consistent with previous reports in the COMFORT studies and also with other studies in patients with higher platelet counts. So this study is now ongoing and it is currently open for enrollment. And of course, once completed, it might really provide important information about the safety and the efficacy for the clinical use of ruxolitinib in patients with thrombocytopenia. Thank you for listening to this activity.